Welcome, everyone, to the 11th session of the Disaster Response Collaborative. We are joined today for our Surge Capacity Focus Area session. Today's title is Incorporating External Partners into Surge Planning. So we have some great speakers for you to talk about external planning or external partners in your planning. So the Pediatric Pandemic Network is supported in part by the Health Resources and Services Administration of the United States Department of Health and Human Services. The content today presented here is that of the authors and does not necessarily represent the official views of, nor an endorsement by HRSA, HHS, or the U.S. government. We are offering continuing education for several groups. If you have a question, if you qualify for CEs, you probably do, but just feel free to reach out to us if you have any questions. Keep in mind that you must attend the entire live session to receive credit. You want to ensure to complete the session evaluation that will pop up at the very end of our session today, and make sure that your name is on the registration. So if you are coming in on somebody else's registration, go ahead and pop your name in the chat so that we have your attendance here. Also, at the very end of the session, there will be a code for you to go to the CE portal and add that in, and that will give you your final CE credit. Few announcements before we jump in. We are very pleased that you've joined us, especially in a short week. So thank you. This session is being recorded. You always have to stop and check. So we will post the recording and the slides to the website by the end of the week. If you have any questions, feel free to type them into the chat or the Q&A. Again, we're offering CEs. There will also be MOC Part 4 for physicians. Again, if you have any questions about that, email the DNC PPN at austin.utexas.edu. I'll throw that in the chat in just a second. But if you have any questions about MOC Part 4, feel free to email me. But again, CEs for physicians, nurses, social workers. Unfortunately, we are not offering for EMTs, but the regular CEs will be available as well. Hopefully your PDPAC survey is in its final stages. You're working on that. Again, that is your environmental scan as well for DRC. So we're dual roles there to decrease more surveys. So we're going to keep the PDPAC open. So don't feel like you have to rush to get the entire thing. But what we'd like you to do is to focus on your surge section and make sure to get that completed. Once that's completed, we can put that into the DRC results because you've signed up for the surge focus area. So that will go into our surge section for DRC. So go ahead and at least get that section completed by July 9th for us. And with all of that, I will hand it over to Liz. Thanks, everybody.
Hi, everyone. My name is Elizabeth Foster. I am a hub manager for the Pediatric Pandemic Network at Rainbow Babies and Children's Hospital in Cleveland, Ohio. It's my honor to be here today and kind of help lead us through some of our session. So the first thing that I wanted to do is just kind of run through the agenda real quick. Obviously, we're doing the welcome right now. We're going to do a quick whiteboard activity, and then I'll turn it over to Vicki and Trevor to talk about working with external partners for your planning purposes. And then we will do some breakouts and we'll have some conversation both around external partners that you have engaged and how that works for you, as well as tabletop, if you have completed your tabletop as a part of the DRC with your internal teams and how that's going. We will come back from those breakout sessions and do a little bit of report out, and then just a few minutes for next steps before we send you on your way, hopefully to have a wonderful holiday weekend. Next slide. In terms of the objectives for today's session, to understand the diversity of external partners necessary for a successful community response to a pediatric surge. Learn ways to integrate and coordinate your individual facility response with the broader healthcare community, and understand how to develop and continue to foster relationships with external partners. Next slide. All right, so we are going to pull up a whiteboard, and what we want you guys to do is to list in the whiteboard external partners that you have engaged with in your kind of emergency planning process as it relates to surge or perhaps others. So if you're unfamiliar with how to do this, you can pretty much grab a sticky note and type into it and go ahead and throw it up here on the board. So which partners do you currently have relationships to call upon during a surge event? Okay, we're seeing that it's working, so that's good. Seeing healthcare coalitions, EMS, police, public health. (211), that's a good one. And what we will do with this at the end is we will compile all of these into a list to share with everyone. EMSC, university, schools, give it another 30 to 60 seconds. Right, we're seeing some wonderful responses here. All right, looks like we've come to a bit of a stopping point, Julie. Oh, I see a couple still moving.
As we move on, what you could do if this cuts off, because I don't know the functionality of that, if it cuts off, you could always continue typing in the chat.
Awesome. Thank you, Julie. And then without further ado, I'd like to turn over the session over to Trevor Covington, who is actually the lead of our mental and behavioral health domain here at the PPN. He also works on RAPM and also Vicky Sakata, who is a senior medical advisor for Northwest Healthcare Response Network. So Trevor and Vicky, I will turn it over to you to share with us about collaboration strategies for pediatric disaster planning. Thank you.
All right. Hey, thank you very much. Thanks to PPN for inviting us to speak, and thanks to all of you. I know this is a busy week with the holiday coming up, and so it's great when I see so many people interested in pediatric preparedness showing up to hopefully learn and contribute to being better prepared. Next slide. Maybe next slide. All right, just as a little background, first of all, I couldn't have a better partner. You all know Trevor. Couldn't have a better partner in crime in this presentation. So we're going to be just kind of having a conversation between the two of us. So we're going to be going back and forth. We'll both be having our own input into this, and it's really a great combination because I am a clinician. I am an ER physician. I'm double boarded in adult and pediatric ER. And really pretty much my whole career has been spent on disaster preparedness and response. And currently my primary role is the senior medical advisor for our healthcare coalition. Thank you all who put on the little sticky notes that you would contact your healthcare coalition. I know healthcare coalitions vary with capabilities around the US, but one of the strong parts of Washington State is that we have a very active healthcare coalition in preparedness and response. And since I happen to be their clinical lead, and since I have a pediatric interest and focus, I make sure that kids get involved in all of our planning. But really, for NWHRN, our main focus and our main vision, as you can see here on this slide, is to have a resilient healthcare ecosystem. So it's not just being prepared, and it's not just responding. It's actually building a community that can withstand disasters better. And we all know that with the world as it is, things are happening. Natural disasters, non-natural disasters, everything in particular that could create a certain havoc within our communities seems to be on an increase. And as this talk emphasizes, it really takes a collective effort amongst everybody to be prepared. I will let Trevor introduce himself. So next slide. Of course, he needs no introduction, but I'll let him speak a little bit about his background.
Vicky's way too nice, and appreciate the opportunity to share with y'all. So howdy y'all. My name is Trevor Covington. Wanted to share, like Vicky, a little bit of the background on how we're coming at this. As she so wonderfully articulated, we have kind of different perspectives, and it sounds like it mirrors some of the perspectives on this call, where we have some emergency managers, some clinicians, and kind of different ways of coming to the same sort of topics. So just want to share a little bit of my background. I'm going to really come at this from an emergency manager perspective. I've done a lot of work in health and human services disaster response. So folks might be familiar with ESFs, so emergency support functions, if you use that to organize locally. Not all communities do, but they're very common. I've been really active in mass care, so the sheltering, feeding, bulk distribution, coordination of volunteers and supplies. I've also done work in short and long-term recovery. All those have a lot of interagency work, a lot of collaborations, a lot of partnerships to get things done. There's not a single function in there that's really handled by a single agency, and it requires quite a bit of collaboration, coordination, support. And then certainly ESF 8, where a lot of folks are engaged. I was kind of looking through, I just got to say, what a wonderful set of partners identified in the initial brainstorming activity. Vicky, I was thinking about our slide later of all the different partners we list. And I'm like, check, check, check. It was awesome and really great to see what folks are already working with. So people are already on a great path. But just noting, I didn't see ESF 8 on there, which makes sense because a lot of folks are working directly with healthcare coalitions, but certainly in some areas where healthcare coalitions might not play necessarily an operational role, or maybe they're not as engaged in kind of the interagency coordination, emergency support function 8, public health, medical, emergency medical services, mental health in some areas is definitely an area I've played in. I primarily come at things from an operations perspective. So I've been an operations section chief for the Department of Health. I got to serve in that role during COVID, which is really interesting when you talk about systems of systems. I would do a lot of work in liaison sort of work, and a big theme of mine is breaking silos, which we continue to try and do both nationwide and in Washington State every day. And I'll just kind of say, an overarching theme you'll hear me share is disasters don't happen in silos. As the folks on this call, if you've experienced it, they don't happen nice and neatly. They don't stay within jurisdictional lines. They don't stay within just your catchment area. They don't just happen. So you only got to talk to one partner, they really cause a whole community need to be get engaged and move forward. And the last little bit I'll share is a lot of background in voluntary organization coordination support. So you'll hear me talk about VOADs and COADs, voluntary organizations active in disasters and community organizations active in disasters. One group I didn't see on there, but I'd certainly encourage you all to reach out to. And we'll talk about that a little bit more as we go on. And Vicki, I'll turn it back over to you as we move on to the next slide.
Great. Thanks, Trevor. So like I said, great combination of clinical emergency management, because as I mentioned, it takes a village. So the question is, why collaborate? And I think we all understand the reason to collaborate, but specifically, there is just a community of people with expertise. We don't all know everything, and we don't know what we don't know. And so reaching out and having others to help with planning is super, super important. Specifically, there is the opportunity to share resources, diverse expertise. This third bullet about shared responsibility is huge, because pediatrics in general, I spent a lot of time in the Healthcare Coalition working on scarce resource management and crisis standards of care. Believe me, pediatric expertise is a scarce resource. You guys are a scarce resource. The number of pediatric beds, the number of pediatric clinicians in and of itself is a scarce resource. And as we know from historical documentation, most children get their care at non-pediatric hospitals. And so the number one focus of our Healthcare Coalition is to make sure that non-pediatric facilities are up to speed with how to take care of kids. Because when there is a pediatric surge, the pediatric facilities are very important, but they're not the only people that are going to be seeing kids. And in fact, the pediatric specialty facilities ought to be reserved for those specialty care pediatric patients that need the expertise. A lot of pediatrics can be taken care of at community facilities. And so I stress over and over again, there has to be a shared responsibility. There has to be backup. There's no way that any pediatric organization individually can manage all of a large pediatric surge. So shared responsibility and having backup, having other people know what your role is super, super important, because if you're gone during the major disaster, you need someone that can step in. And as Trevor already mentioned, disasters don't respect silos. So there are no boundaries when it comes to disasters. Next slide. And we always have to keep in mind the major goal, which is to better prepare and better take care of kids. So thanks. Next slide. And if you can click again, this is the big news flash. This is like my most prominent soapbox when it comes to pediatric preparedness. And I know we've heard over and over, how many clinicians are in the audience, that kids are not just small adults. Well, my news flash to all is that kids are just small adults. By focusing too much on kids that are not just small adults, we tend to isolate our expertise and say that, oh, hands off, no one else can take care of kids except for us that are pediatric trained. And that creates more barriers. And what you want to do with disaster preparedness, especially for kids, is to break down those barriers. You need to teach people how to stabilize kids. You need to teach people that they should not be afraid. The heart's in the same place, the lung and the liver, they all are doing the same function. So I like to always start out talks when I'm giving, especially to adult communities, that you can take care of kids. We need to open this up. We need to make sure that all of our partners can feel comfortable taking care of kids. So when you work and engage with partners, next slide, we're just going to list a few objectives and tactics to use when you engage all these partners. And when you look at that whiteboard that you just did, and you look at all these various partners, it can be a challenge. Let me tell you, it can be a challenge bringing a lot of people together and really focusing in on what your project is going to look like. And what Trevor and I have come up with in these next few slides are what we feel are sort of the keys to a path towards success. We want you to be able to collaborate with folks and move forward in a successful manner. So one of the main things I see where collaboration doesn't work is when there's not focused goals, or when the goals are too broad and non-actionable that you get lost in the weeds too often. So I think one of our key messages would be that when you get a group together for collaboration, you need to sit down with all of the partners and come up with a common, realistic, and actionable goals. And in the blue box here, we've kind of thrown out some suggestions of goals that are way too broad, like let's improve pediatric situational awareness. Well, what does that actually entail? What do you mean by improve pediatric situational awareness? And what do you actually mean by situational awareness? Is it beds? Is it space? Is it stuff? Is it staff, et cetera, et cetera? So potentially a better goal to that is develop situational awareness dashboard or information sharing processes, et cetera, so that your goals are more specific and can be understood by everyone. The second example is very broad. We just want to take care of kids better. And on the aside, on a potentially better approach to this, and I'm such a fan of exercises. So conduct a tabletop exercise that which includes kids, and that in and of itself will bring forward specific goals and action items that you need to address. Trevor, did you have anything to add on that at all?
No, I guess yes, one little bit, and that's the actionable piece is just so important. Very often we get folks together with like a vague feeling of like we should do something positive in this topic, right? Which is great, and it's awesome that folks want to come together and support it. But having very actionable and clear goals isn't only important just because then you have something to get done and then you can check it off. But what it does is it really kind of creates momentum, right? So if you have the vague, undefined goal, you don't really have the sense of progress. And we'll get to it in the next slide as we talk about it. But being able to see that progress, even if these are small to start out with, even if they're not, these big things where you're creating a dashboard or really you're, undertaking a big MCI surge plan, something as simple as, understanding the partners at play, right? And being able to have a contact list to start small. Those can be your common, realistic, and actionable goals, particularly as the partnerships are new and budding. So that's all I'd add. Back over to you, Vicki.
Great, thanks. So next slide. As Trevor mentioned, you almost already filled out this slide yourself when you were doing the whiteboard, but we'll just make a few comments on the partners that you should definitely consider getting involved when you talk about pediatric healthcare and pediatric surge. And one of the things, you guys can all read this list, but one of the things that I have felt that has been very successful in Washington State. There are in Washington State only 4 pediatric specific hospitals. And just actually getting all 4 of them together in a work group with pediatrics focus has been really an incredible endeavor. And I have come up with so many common and shared goals that every institution is thinking about, every pediatric institution is thinking about, but there's power in having and working together. There's power in having shared and common goals. And there's also, I find, less waste of time. It's one thing if one of your institutions is working on an MCI plan, but everybody needs an MCI plan. So why not all the pediatric facilities kind of work together and share some ideas on how an MCI plan would look like? And now in my role here at the Healthcare Coalition, I see everything from a much higher level, a 30,000-foot level, and having that regional coordination is so important. So I've highlighted the non-pediatric healthcare people, getting them involved, getting to understand what they're facing is really super important. Trevor, I'll let you run through the government agencies. That's your field. You know all these acronyms and stuff.
No problem.
Yeah, thanks.
Yeah, I got all the letters down.
Yeah.
So certainly collaborating with government partners becomes a much bigger thing, depending on the function, depending on what your local preparedness and partnership environment looks like. Like we mentioned previously, a lot of the direct collaboration might be handled by a healthcare coalition, but if they're not operational in your area, if they have a kind of a different scope or function, certainly we're working with public health, Department of Health, whoever kind of owns the credentialing, the oversight, the policies, the support. Apologies. Just had a doorbell go off, so apologies for the screaming kid and puppies. Yeah, DSHS, certainly for intersections, not only their day-to-day programs, but a lot of these government agencies kind of have different functions that they activate during a disaster, right? So they might get something like the crisis counseling program. Very often that can go to a healthcare authority or DSHS. One thing that I saw a few folks call out, but I always just want to point out mental health. My philosophy is you can't do surge management without doing mental health surge management. I think it goes one to one, particularly when you get into CBRNE sort of incidents. There's a lot of precedent around worried well, complicating triage, all those sorts of things. So I think, anytime you think about surge management, anytime you think about throughput, I think you need to think about mental health as well. So I think those overlaps are really important. We talked about the emergency support functions. Definitely something to consider. I want to just recognize they're not used in every community, but they're used in quite a few. I will call out there's probably some evolving guidance on structures and kind of approaches to emergency management coming out of different changes at a federal level. So whether or not those will stick around or change is kind of yet to be seen, but there'll be some form of coordination structure for things like mass care, sheltering, and public health and medical. Why am I talking about sheltering? Certainly, there might be requests for support from your community in community shelters. And I've worked this sticky issue from a few different ways of a medical shelter, right? Who owns that? Is it the sheltering team? Is it the healthcare facilities in the area? What does that look like? So that's a pretty clear Venn diagram of collaboration there. And then to what degree it stood up locally, the RSFs, the recovery support functions, or any sort of other planning mechanism. Really want to encourage folks to plug into that. Looks like we had a lot of emergency management expertise on the call. So folks caught a lot of these. Just want to emphasize the mental health piece. I saw a few folks list schools as well, particularly for reunification. That's definitely a big component. That gets really complicated, especially if you have any on-scene spontaneous triage. Reunification with the school district becomes, definitely an interagency sort of function. Some folks captured transport. One thing we didn't have on here, but I'm just going to throw out there as well, utilities and supply chain, definitely ones we want to call out as well. They have some indirect impacts, obviously, on pediatric programs and supports. Vicki, back over to you.
Yeah, excellent. And I would also just echo, and I think you all realize this from your perspective, is that each of those functions that Trevor mentions, a lot of them, their primary focus is adults. And so they don't think a lot about kids. For instance, having shelters, putting shelters together, or having, specific reunification centers, having a pediatric voice on all of those plannings at your public health and governmental agencies that are doing a lot of that planning is really super important, because they tend to forget sometimes about the kids in general. So I would also mention that the other considerations besides the people is your geography and your hazards. So the geography that in Washington State, for instance, we have a large mountain range that essentially cuts our state from north to south. So in times of winter, when you can't cross the mountains except for flying, that changes what your surge response is going to be like. Your certain hazards will change what your surge response is going to be like. If you have hurricanes versus earthquakes, those kind of things will also change what you need to think about and who's involved in your village when you get your village together. Knowing where your subspecialties are located, it has been shown, I think actually Mary King, who I think you all are very familiar with, Dr. King did one of the landmark studies, her and Kay Coulomé, showing that all the pediatric subspecialties are focused in urban areas, and most of the kids live out in the suburbs. So, there's a distribution problem as well. And so trying to think about how that's going to work with surge planning is something to take into consideration. All right, next slide. All right, so you've identified your partners, you're coming up with good, actionable, common, realistic goals. And so now what do you do when you have this whole group together? This slide is to kind of, these are really soft skills. You know, as healthcare people, we are trained so much on, you know, diagnosis, differential diagnosis, procedures, how to do things, very concrete goals. These goals, I never was taught them in medical school, but I wish I had. I just kind of learned on the job. And these are very important goals on how to build partnerships. And you really do need strong leadership. So the box on the left is the steps toward success. If you really want steps toward frustration, go ahead and follow the other box, but that's what will lead to a lot of frustration in a group. So steps for success is to have strong leaderships. You know, you need to build, as a leader, you need to build trust and respect. And how do you build that trust and respect? And a lot of times I think it's that you deliver on what you have promised, or what your work and your goals are. If you deliver on your goals, then you build that trust and respect amongst your community partners. Again, we've mentioned over and over having clearly defined steps and goals, but also clearly defined roles and responsibilities. I would also say that you really do need to level load a lot of the work that's being done. There's always one or two partners that will volunteer to do everything, and that's wonderful. But when the responsibility is shared, then that also brings in the partners more. It makes them more engaged. And when they have a shared responsibility, then they come prepared to actually fulfill that responsibility. Make sure there's always feedback loops. If you're putting together a process, then you need to test the process. You need to make sure that you're getting feedback amongst the people that are going to participate in this process. That is always an important part of any of these partnership buildings. You need to be flexible and adaptable, i.e. you need to compromise. And that is super important when you come to a group with an already set expectation. You need to be open to other people's expectations, other people's thoughts and processes. Even if you don't think they'll work, they need to be at least engaged. They need to be recognized. And that plays into what is often called active listening. You need to listen with the intent that you want to understand. People can tell if you're not listening. And so you need to listen and to at least acknowledge the different input that is that plays into group projects and group meetings. I will turn it over to Trevor. You can take the last few bullet points. That would be great.
Yeah. Like I said a little bit at the start, I think it's important to start small if you can. Get some clear wins, show that the team can actually achieve things and move towards their objectives. That kind of creates its own feedback loop of its own. You know, success begets success. You know, this can start really small initially, you know, having the clear scope, making sure we have a contact list, we know who's at the table, we've developed partnerships, we're not exchanging business cards day of the disaster. You've probably heard that phrase if you worked in the space for a little bit, and grow those over time. You know, one of the things, and I know it kind of cut out there should be a little arrow as opposed to a question mark, but if you plan together, if you train together, if you exercise together, you're going to be able to respond together. So if you're conducting the same sort of hazard and vulnerability analysis in a region, if you're talking about the same sort of concerns, if you're planning and making sure your plans are interlinked, they have the capacity to refer to and support one another. If where you're able to, you conduct joint trainings, or you invite your partners to trainings as well. And certainly when you're able to practice together in exercises, everything else moves so much smoother during response. You kind of create that muscle memory over time. And then, you know, continuing with the village theme, make sure you have your village on speed dial. It isn't unusual for me to text one of my partners throughout the week and just ask them a question. I know I've blown up Vicky's phone plenty of times, right? But being able to reach out and collaborate, making sure that, you know, you have that trust and that partnership. I can tell you I've worked quite a few disaster responses, and there's always the formal process, but particularly where partnerships are built, you kind of almost have that informal inquiry ahead of the formal inquiry of like, hey, we need the support. You know, here's what I understand the process to be. Just want to let you know, Bob, I'm sending a request your way to your agency, right? So it comes with that little bit of a little bit of a heads up. So while we're all about process and formality and chain of command, I also want to recognize there's definitely a clear use and need of kind of that informal communication chain as well, and building that trust in the partnership that you can call on during those really sticky and challenging days is really important. And then won't belabor it, but certainly off to the right, I imagine all of you have encountered these steps of frustration that Vicky pointed out. The no clear target, I think, is the bane of so many groups. A lot of well-intentioned people that want to do good things just have a vague sense of we want to cause something positive, right? But maybe it's the ops guy in me. I got to have objectives. We got to have deadlines. We got to knock them out. But I think that clarity of purpose and that movement's just so important. So, Vicky, I'll turn it back over to you for the next slide.
Yeah,
Or
absolutely.
maybe
I
I
would
won't,
also
actually. Looking at it. Sorry.
No, I just want to follow up on one thing as you were talking there, Trevor, when you mentioned the muscle memory, and then on the right box, I put in ignore. If you want to have steps toward frustration, ignore current processes, and that brought to mind if you're going to create successful disaster procedures, don't make them brand new different procedures. Try to align with procedures and processes that are already in place so that people can start create muscle memory on their during their everyday work. So you don't want to introduce, like, you don't want to exchange business cards on the day of the disaster. You don't want to also implement an entirely new process, like all ER patients, you go to the other door. That is not going to work when they're used to coming into the primary door. So making sure you recognize current processes. All right. And the next slide, I think, pretty much is all yours because it's the emergency manager slide. Oh, yes. There you go.
There we go.
Okay.
I won't belabor the point, in the interest of time and some of the things we've talked about, but just kind of looking, for me, I always look at across my emergency management program, what are the integration points? To Vicky's point, what can you tap into already as opposed to creating something new, right? So hazard and vulnerability analyses, is pediatrics a focus? Is it even a data point? If I could do Control F on your hazard and vulnerability analysis, does pediatrics or children or you show up anywhere in there, right? Even just the knowledge of where kids live and where services are provided, that's definitely a key consideration, particularly when you have things like transportation, single points of access, right? If you have a bridge between cities, or we have Portland and Vancouver, right? So we have a lot of folks that go across the state and the river to work during the day. Well, just even knowing that as part of the hazard and vulnerability analysis is really important. And the impacts of what happens when all the parents are on one side of the river and the kids are on the other. Mitigation, identifying opportunities for joint mitigation initiatives. So is there anything where we can help all sorts of groups involved? Advocacy strategies. For me, I got to say mitigation is becoming more and more of, it'd sure be nice to have more pediatric beds. I know that's weird to think of as a mitigation strategy, but when it comes to system fragility and avoiding surge, more and more, I just keep thinking about, even just advocacy around that becomes more and more important. Planning, certainly we talked about interlinking plans, jurisdictional regional planning. I know folks have mentioned load leveling, surge management. That stuff doesn't happen in a vacuum. I know I'm preaching the choir, it doesn't happen in a silo. So how can we plan for an interagency level? And that directly goes to training exercise. Like I mentioned before, where can we do that together? It's awesome where possible to identify shared training needs and bring those in. So certainly, you might not be able to justify a training need within your organization, but maybe locally there's a whole set of folks that need it, and you can all pull in together for some training or exercise work locally. Then equipping and organizing, once again, same sort of thing. Maybe there's opportunities to create joint interagency strike teams or task force or what have you. You might not have the resources you need within one facility, but you can create shared resources that can support. And lastly, like we talked about before, you're doing all this day to day, responding and recovering is going to come together naturally. So that's kind of the common theme. Back over to you, Vicky. Next slide.
Okay, the infamous mute button. We're going to just wrap up. I know we're running short of time. We're just going to wrap up with a few examples of putting this all together. And again, I mentioned previously the NWHRN, our Healthcare Coalition, has had a longstanding pediatric disaster and surge work group. And it's where we brought all four of our state pediatrics specialty facilities together. We also have community pediatricians that also are involved as inpatient and outpatient resources, and we meet monthly. And I should, let's see. Why don't you go to the next slide? I'm just going to share just some examples of what has come out of this work group. So on the far left, we now send out a daily pediatric situational awareness report for all of Washington State. It shows bed availability from NICU to Peds Med Surg to PICU availability. It shows how many kids are boarding in hospitals. And that all came out from working with this pediatric surge disaster work group and starting with an Excel spreadsheet that we all contributed to. I mean, and has turned into a really great and informative way that this report goes all the way up to our governor's office and DOH and Secretary of State of Health. So this report is published daily, Monday through Friday, but we do collect the data on the weekends as well. Also from this work group, we started last fall a pediatric fall respiratory refresher course. Every fall is the pediatric surge event. Fall season comes, respiratory viruses come, and kids start showing up at every local ER, including non-pediatric facilities where a lot of the kids are being taken care of. We started in a preparedness mode. We started in the spring and summer thinking, well, maybe we should offer a refresher course, just teaching nurses, doctors, clinicians, RTs, how to take care, a reminder of how to take care of kids in the wintertime. And when we started putting this together, I thought I'd be happy with like 50 or 60 people showing up on this webinar. Well, 400 people signed up and about 250 actually showed up in person on the day. It's a 2-hour webinar. Most of them were nurses, which are great. And their questions were phenomenal. It's like, how do you suction kids' noses? How many times have we in pediatric ERs had taken patients that had been transferred for miles to our ER just to have their nose suctioned? Well, let's teach people how to do this. So to me, it was fabulously successful, and we're going to do this again this coming fall. Every fall, we have a pediatric surge. So that is something that has come out of this work group. And again, it wouldn't have, the speakers on this work group were people from each of our pediatric specialty facilities. It wasn't just one pediatric hospital, it was all 4 of them that were represented. So everyone from a community PICU to our academic UW Seattle Children's Hospital, which is really great. And then the third slide here just shows something that I think we should all strive for. And that is with any exercise that's involved, when you hear of any exercise that's being run either through public health or any of your other communities, if they add just a few kids to that exercise, you will be able to find the gaps in your planning. And this is just an example of our annual Mercy exercise that we do that's required by ASPR. But we had a bunch of kids in all different red, yellow, green, black cases, and having that exercise done throughout the state was really beneficial and showed a lot of where our gaps are and where more work is needed. So through this collaboration, through getting all these partners together, things like this can happen. I will say, however, these things don't happen overnight. Our pediatric surge work group has been active for probably about 10 years, but COVID really lit the fire underneath them, and a lot has been accomplished in the last 3 to 4 years in general. I really appreciate the group that shows up, every month. Next slide, I think Trevor has some examples, and then we'll turn it back over to our PPN colleagues.
Yeah, I'll be pretty quick. I just kind of want to build on something you said. This is pretty much what you've heard from me already, but like Vicky shared, having a few kids interjected in those trainings or the scenarios is really important. And I'll just call it out from emergency management perspective. Doing anything else is fantasy planning. It's wild to have the idea that you could have a disaster and a group that makes up 25% of the population wouldn't show up, right? It is when you have a disaster, when you have an event, kids are going to be impacted, and failure to include them as part of planning, training, or exercising is doing emergency management in a fantasy sort of way. It's pretending that we won't have these complications, which we know is not reality. So if I could just kind of put a point on that and build on what Vicky said and put a fine period at the end of it, that would be my bolded period, right? Is failure to include pediatrics in any sort of these activities is simply just fantasy planning. And then, the last thing I'll say is if we're giving you all these recommendations and you're not finding any of this locally, that's a pretty good indicator of where you might want to start, right? So if you don't have an engaged healthcare coalition, if there isn't a lot happening around ESF8, some really rural areas, this might happen in the local emergency planning committee, right? The LEPC typically focused on hazards and specifically so it's chemical, nuclear, et cetera. But coming from rural Idaho, those were kind of all hazards general planning sessions for us. It might look different locally, but if you work with your emergency management program, or if you're part of it, you reach out to the county, you're not seeing any of these pieces locally. That's a pretty good indicator that might be where you want to start, is figuring out where these conversations are happening. Is there a coalition you can build into? Is there a coalition that already exists around healthcare you can add a pediatric component onto, right? So you don't have to create your own thing. Is there a pediatric lens that we can add to already existing initiatives? I just want to kind of call that out of, if we're giving you recommendations and you kind of run into a dead end, I would encourage you to think about that as a dead end, but pick up your sledgehammer, start working on the wall, and that's the next silo to break down and next piece to build for your community. So that in mind, I'll turn it over to Vicky to wrap this up. Thanks.
I have nothing left to say. You have said it all, Trevor. Thank
Okay.
you so much. Oh, I guess we do have one last thing to say, right? I heard this comment at a response conference once, and essentially what we've outlined before is communication. I mean, all of collaborating with your partners is all about communication. So I would hate for you to all think that communication is just a part of a response, but it actually is the whole response, and it's the whole preparedness cycle in general. All right, now we're done. So back to you, PVN.
Thanks. Are there any quick questions for Vicky or Trevor before we go into our breakouts? Okay, hearing none, we are going to split up into a couple of breakouts, 2 or 3 breakouts, so they will be a little bit larger this time. And the first question that I want us to think about is, for those of you in the breakout that have done your tabletop, can you please give a unique or interesting idea or process that came out of that, or an obstacle that you faced that you were able to overcome? And then we'll go ahead and get into that in the breakouts, and there are additional questions if we work through that. So I will let Julie break us into our groups, and I think we'll take about 10-15 minutes in the breakout, and then we'll come back. All right, welcome back, everyone. Hopefully you had great conversations in your breakouts. So before we close up for the day, we just wanted to hear a couple of reactions from each of the breakout groups. I believe I was in breakout room 2, so I'll just go first, and then we'll call on 1 and 3 leads to share with us. With regards to the conversation about how the tabletops have went, we did have 3 in our group that had participated in the tabletop already, all kind of leaning towards learning a lot from those, especially as it relates to external partners and how to and who needs to be engaged moving forward. I think the benefit also being recognized that just bringing people together for the tabletop was really helpful in and of itself. And then a lot of individuals, I think Lauren from Valleywise in Phoenix said that that actually is leading to them creating a pediatric annex for their hospital. So that's going to be a great document that they will have. PEDS is mentioned in their current documentation, but not at the level of detail that they recognize that they need. And I think that Julia in Oklahoma is hoping to host a tabletop with external partners as a next step. Is that something that they've identified that they wanted to do? Lurie and Maureen, they're working on discharge lounges and some of the patient movement pieces for patients that are ready for discharge in that kind of surge event. So I think we identified both some things that we're excited to work on, and it was overall a great opportunity. And I think those who had not participated yet definitely saw that it's a benefit to participate in those tabletops. So who had breakout group 1? Is there anyone that would like to share what their group learned?
Was I one? I'm not sure if I was.
You can be.
So
We'll just make you one, and whoever.
I'll one. My group, we had emergency management clinicians, kind of mixed evenly. Tim from Arizona discussed the very unique position of being a children's hospital within a larger hospital. This is a really important constituency that I think the extremes of community with no PEDS focus and those of us in speed specialty centers, we don't think about the folks that are trying to do everything in their center, and PEDS is within that center. And sometimes they exercised their surge in a tabletop and really identified who they would have to partner with for additional inputs in mental health space and some other pediatric specialty area spaces. But the surge tabletop kind of outlined for them their gaps, and that was really great to hear. Another emergency management professional is located in a hospital that can't really say no, a specialty hospital that can't say no, but yet their surge space is kind of filled with some adults that kind of took up residence, and getting those adults out of that space in the event of a big surge would probably not be a realistic or possible quick event. So this is a common refrain I hear from folks either in a combined pediatric adult hospital, children's hospital within a hospital, a community hospital that has a few kids beds, or even a large center where will we surge to? We're all competing for that same space. And so they are looking into thinking about what are we going to do about that? And also they are such a large regional catchment for children in their state, they can't say no. So if there's a surge within many, many miles around, and I think Dale said 150, they got to say yes. And so they don't have a choice. So that's a conundrum that they're thinking through. And Tanya, program manager for trauma in another combined children's and adult hospital, is worked on evacuation as a concept, and uncovered gaps in their evacuation hygiene for the pediatric floor, and is thinking about a horizontal evacuation exercise that they want to do when they really get their plan in place. So this wasn't really necessarily the evacuation work group, but I'm glad somebody brought up evacuation, because that is essentially a surge in by a different name, and is extremely disruptive to the care of these patients. So, and she spoke about when you're going to evacuate, whether it's horizontally or down a floor or two, everybody wants that PACU space. Everybody wants that well equipped and nice space that is pluripotential. And that's what she's struggling with. So you have to think about who is going to get how do we prioritize who's going to get the space. So some really interesting problems, gaps, and solutions were discussed in my group. So thank you.
All right, and then who had the final group?
That was me. I think, we did talk a lot about, I think one of the successes that we heard about was partnering with another hospital to actually accept some of the more stable older children to kind of offload, especially since it was Dawn from El Paso Children's. So they took care of most of the specialty patients in their exercise, and then offloaded some of the more stable older ones to a different hospital. And that was actually, that worked really, really well, and that they were able to surge into multiple different areas in their VTTX. One of the interesting discussions that we had was about the lack of awareness outside of the institutions as to like how broadly a respiratory surge, like what happened in 2022, 2023, how that actually impacts like outside of the hospital, right? Like, so for every kid who gets admitted into hospital, there's like probably a dozen that don't or that are held in outside EDs. And so the actual impact of a respiratory viral surge was not actually kind of imprinted upon leaders who of inpatient and critical care units. And so I think that was a big challenge. And really having like funding and bandwidth to do additional training for some of our community partners out there in hospitals that don't always see children. And I think that was something that we talked about. And then Vicki did bring up the idea of the PMOC to help level load pediatric patients across a region. You know, I think there are some areas where that's very well established and others where it's really hard to establish. And so it would be curious if anyone else has like any tips or tricks around that. Thanks.
Awesome. Thank you, everyone. We're glad that those tabletops are continuing to be a success, and we look forward to hearing some more next month. And I will turn it back to Julie.
Thanks, Liz. Thanks, everybody. I am really excited about hearing more about the tabletop exercises. I know a lot of you have really put a lot of work into that, so thank you. So we wanted to check back in with the checklist and where we are in the DRC. We continue with our monthly sessions. Again, the PDPAC is ongoing. We're not going to close that. We want as many submissions as possible. We want to gather that national data and really show where we are as a country. As far as using that for the DRC environmental scan, we're asking that you at least complete your surge section, the section of the PDPAC on surge, or your other focus area. If some of you have 2 focus areas, go ahead and complete the focus area sections at least. This QR code gives you, sends you to the page for the PDPAC so that you can still register. Also put that in the chat if you need that. The other thing that we're collecting right now is the tabletop exercise data collection survey. So I sent that to the team leads, the facilitator and the evaluator if you did a virtual tabletop exercise. So if you don't have that, and if you haven't heard of that at your hospital and you know you've done a TTX, let me know. Send me an email at DNCPPN, and I will get you your hospital's link for that survey. And then it's not too late. It's not too early to start planning your full exercise or full drill for the fall. We want to see those start to happen. So you did your tabletop. We talked about it. We found some gaps and barriers. Let's tweak some of the plan, and then we're going to really play it out and do a drill in the fall. So there's more information will be coming from the DRC team in the next couple of months, but go ahead and start planning that, maybe who should be there and what day you want to have that. Upcoming sessions, this is the QR code for the August session. And I do not have the link copied, but again, the follow-up message to this week's session will be coming out in email and then later on in the week or next week, and that link to register for the August 5th session. If you came to the June full collaborative session, it's the same link that you used that day as well. And then again, emails and calendar invites for the September 2nd, where we'll come back for surge. I apologize. I copied and pasted and missed a detail. So we're not evacuation. This is the surge session. You'll get that link in the next coming week as well. Here is the continuing education code for you. So you can go to the CEPEDS pandemicnetwork.org, and that will, and then put in that code GEXCUC, and that will get you your continuing education credits. And finally, I've put the link to the evaluation, and then also you have a QR code here that you can use to provide any feedback you have for today. We love to hear the feedback. We've heard a lot of good feedback and used it. It helps us create a better session for you. So please fill out that evaluation. And thank you everyone for coming today. Thank you for spending time with us and giving your input and sharing. We all learn from each other, and that's what this collaborative is about. And we've heard some really great things. So we hope to continue to hear from you. If you need anything, please don't hesitate to email that DNC PPN or reach out to us in any way. Have a wonderful week. Happy 4th of July, and we'll see you next month.